Um, Brief overview of how I envisioned this panel going. So after this brief introduction, I'll hand it over to Dr. Gupta and Dr. Peters, and they're going to talk a little bit about the Johns Hopkins India Institute and some of the great work that they've been pursuing the last couple of years. And then we can then talk, go individually with the faculty. And I kind of envisioned this to be sort of like a Q&A format. If you have any questions and you don't want to like unmute yourself, feel free to message me or message any of my classmates here, Shrey, Divyansh, and Pranjal. But you can also just unmute yourself and ask the question. So without further ado, Dr. Gupta, if you want to introduce yourself and talk a little bit, and as well as Dr. Peters.
Sure. Well, hi, everyone. Good evening. I also know, I think Dr. Garima Sharma, who's from cardiology, has to leave at 5:30. So what we'll do is we'll each introduce ourselves, a little bit about our work, because we represent different facets of working in India with South Asians, both here in the US and internationally, with different kinds of engagement with India and the South Asian continent. So first of all, I'm really excited to have the chance to engage with many of you who I believe are all medical students. And if you want to put yourself on video, we'll say hi to you and get to know you. But I think you're at a very exciting point in your career. And I remember when I was a med student, I had the chance to kind of figure out what I was going to do. I was looking at what kind of world would I go in the health policy world and study breast and cervical cancer, and or would I go do field research? I spent 6 months in Guatemala learning Spanish and doing field epidemiology with figuring out how many babies had died in these rural villages, going door to door. And that got me really interested. And so the short answer is then I ended up sort of doing, going to UCSF and did my residency there in primary care, got really interested in HIV. It was where we had the antiretroviral era first, 1986, when triple ART with 24 pills a day, figuring out how to give patients their treatment. And then by the next year of residency, everybody, the whole ward basically didn't have any more patients. And so we were starting to figure out outpatient management with these drugs. But I happened to have a chance encounter, and I met one of the residents who was at CDC and had done the Epidemic Intelligence Service. And I was like, that sounds super cool. So I left residency and went to CDC for 2 years and did the EIS program and did diarrheal disease outbreaks. And so I got to do some cool cholera work, typhoid in Vietnam. I went to dairy farm outbreaks on farms. And then I ended up realizing that it was really wonderful to do this work, but I missed some of the clinical work. So I ended up coming back here. And the reason I came back was because there was Professor Bob Bollinger, and he was doing work in India, and he had the first phase 3 HIV prevention trial looking at breast milk transmission using a drug called nevirapine. And they were looking to block the transmission by giving the babies nevirapine. And so ever since then, as basically coming here, not really having any clear sense of where I was headed, but just liking everything I was doing and then following the next lead, I ended up here doing infectious diseases as a fellowship, doing the master's degree at the public health school. I got to get to know Shruti early on in my career when we were both sort of a few years younger. And I've basically been working in India since and been doing clinical trials. So that's a long way to say that, I'm hoping that you will find your passion. We have a lot of exciting things happening with the India Institute. I'm just one of many people working in this space. It turns out Hopkins has a wealth of faculty and staff engaged with India, many of whom have given their time here on the call. And I'd love for you to hear about them. But the mission of the Institute is to sort of mobilize Hopkins students, faculty, and staff to be engaged with Indian partners to really impact global policy, practice, research, and have sort of meaningful outcomes. And so we're in our second year of existence. We have actually done a lot. One is to convene all the sort of start mapping out all the amazing work that's happening. And I'm going to stop there because I want to know that many others want to speak and you want to hear from them. So I'll pass the buck to David, who'll tell you more about JHII and what all we're doing.
Great, thanks, Amita, and great to be faculty co-chair, I guess, of the faculty steering committee for JHII. I'll go back, as you asked, about how we got started in this in the first place before going back to JHII. So I went into medicine thinking that was a way I could get to work internationally. I was from the prairies in Canada and didn't have too much insight in terms of how to do that, and I knew I wasn't cut out for missionary work. So I went into medicine and spent the last part of medical school in Nepal, actually. At that time, my parents were living in Calcutta, and I found the opportunity to both visit them and then travel all the way across Nepal, or rather the width of the country, and then spent a few months in working in the Middle Hills there. And that's where one of the places where I learned about the limitations of care, and both at the population level and the clinic care level. And then when I came back to Canada, I after graduation worked in northern Canada on Indian reserves. But in this case, really, again, recognizing the limitations of what you can do in very difficult environments, but also, how important social structural determinants are in terms of what you can do in terms of improving people's health individually as well as at family community levels. So I tried to find where public health was, because we didn't have any in Canada. And I came to Hopkins a bit by accident, because my plane to go to view London School of Hygiene didn't work out, so I ended up at Hopkins, and loved it ever since. And that's where I learned about public health. Fell in love with the field. Got to do work all over the place. Did my dissertation in Sri Lanka, but also worked in India, Philippines, Nigeria, a lot in West Africa, and it was something that was really, again, an eye opener. After graduation, I got pulled into the World Bank. It was not something I ever planned. So much like Amita, I guess we didn't really have these planned careers. But I ended up working at the World Bank. And after quite a few years in West Africa, I actually ended up living in Delhi and working in India, and really was able to pull together lots of Indian institutions to work on research around really around inequities of care and financing. That's where the discovery of first of all, people falling into poverty as a result of illness, and particularly hospitals, even in public hospitals, and the great inequities even in public spending, and how that was disenfranchising people and being unfair. And so that really became motivation for further work. It actually helped stimulate the first rural health mission and a much of policy. So I got a good understanding of how you could actually influence policy through research. Anyways, from there, I came back and forth between Hopkins and the World Bank. Have always had a commitment to being working in India since that time continuously, and it's been a great learning experience for colleagues. For the Hopkins India Institute, I'll do very quickly. This has been a remarkable opportunity to bring together faculty, staff, students, and alumni, and all the partners that we have who are working in India. We had no idea how big and deep the Hopkins collaborations and work in India have been. We've been there since the 1930s. And I'm now talking about the university, and particularly the health schools. Then we find out as we do the exploration how many hundreds of faculty and students are in there. So what we've been able to do over the last year, yes, we've created this institution together, finding out what everybody is doing, and then coming together, I would say coming together at a time of crisis, and we'll hear more about the COVID response. That was really remarkable. People from all across, medicine, nursing, public health, coming together, partners around raising money and immediate impact with our partners. Yes, we raised over $2 million, but really deepened our our collaborations and response. And since then, we've built it up further. being able to, I think, create a really exciting strategic plan and really trying to find ways to amplify what faculty, staff, and students are doing in India. So I'll stop there. I'm not going to give you a presentation of the strategic plan, as tempting as that is. I'll save that for our meeting with the Indian ambassador tomorrow, or maybe you will, Amita, and then turn it back to you, Ashish, and team.
Sure. Thank you so much, Dr. Peters and Dr. Gupta. So Dr. Sharma actually has to head out soon. So if you would like to say a few words about what brought you into this kind of research and I guess like what your role is here at Hopkins and what gets you excited about being here, about the work that you do.
That's great. Thanks for having me, Ashish, and thank you very much, Dr. Gupta and Dr. Peters, for giving such a beautiful overview of your mission and vision and strategic plans. It's really remarkable to see how much has been done within a very, very short time when all the rest of the world has been impacted by COVID. So kudos to you and your commitment. And to all of you who are here. I actually found out about this very recently through talking to Dr. Gupta, and I've been very excited to be on board and listening and understanding what I can contribute. I am a cardiologist. I am not an infectious disease doctor. My focus is cardio-obstetrics. I take care of pregnant women with cardiac problems. And we know that that is a huge problem in India, especially more so in the rural areas. I trained in India. I was born and raised in India. I lived there till I was I finished medical school in India as well. I moved here in 2004. I did most of my advanced training in Texas and then at Temple University in Philadelphia. And I've been on faculty since 2014. And so I have actually lived through a lot of what Dr. Gupta and Dr. Peters are describing. There is a huge amount of inequities. When I trained, which I would like to believe is not that long ago, I do actually remember a lot of these trials that they're talking about where, which were trials that were happening in the HIV space in India when I was a medical student. And if you're a medical student in India, especially in sort of the schools that require you to do rural training, you have to actually spend about a year working in a very resource limited rural part of India. And I do remember, the kind of challenges that you face in terms of prescribing medical therapy for very preventable diseases. And I'm hoping that that has changed. And I know that that will have changed in the last, maybe 15, 16 years that I've been there. But, in the late 1990s, when I was doing a rural rotation, I do distinctly remember that erythromycin was actually the only drug we could afford to treat everything. And so, I think India has come a long way since then. My passion is focused on the disparities in care, especially for Indian women, where there is a definite bias. Maternal mortality in India is high. It's mostly impacted by fragmented antenatal care and preventable disease. And so I think my interest really lies in finding synergies with what I do and what I have passion for and relating that and helping in any way I can. So thank you for having me. I don't want to take much of your time. I'm actually just here to listen and learn and appreciate what has been done. Thank you very much and congratulations.
Thank you, Dr. Sharma. Now we can turn it over to Dr. Solomon.
Sure, thanks, Ashish. I'll be brief. So I'm like the stereotypical Indian story. I'm a boy born into a family of 2 Indian doctors. So even before I was born, I was meant to be a doctor, right? I think most of you know those stories. But unfortunately, my dad actually started open heart surgery in Chennai, and my mom identified the first cases of HIV in India. So I was born into a little crazy overachieving family. So I grew up with dining table conversations about open heart surgery. My dad would bring home hearts and dissect them. My mom would be talking about blowjobs to me when I was 8 years old, and I had no idea how to respond to it. She's like, "Oh, I was in the school doing this education program, and the student asked me about a blowjob." And I'm like, and when you're 8 and your mom asks you about a blowjob, you look, like, do I know the answer to this question, or do I not know the answer to this question? So it was a little tricky growing up. So I finished high school, did my medicine in India. When you do medicine in India, you don't need EIS. You pretty much see every infectious disease under the sun in abundance. And so that's the kind of exposure you get from doing infectious diseases in India. Because most of you probably know that even today, like infectious diseases probably is like the largest burden of internal medicine cases in India. We don't see the standard internal medicine cases that you see over here. So when I finished medicine, I really wanted to go into surgery because I loved working with blood and getting my hands all dirty with blood. But when I spoke to my dad said cardiothoracic surgery is too downstream. The very few people can actually afford it. You actually have to go upstream and prevent people from needing surgery, right? Because that really is the goal. And if you actually look at India as a healthcare environment, you can get the best healthcare access in the world in India, but at the same time, you can get the worst healthcare access if you don't have the resources. And so that's pretty much where I pivoted more to public health. And at that point in time, HIV and infectious diseases was the bigger problem. So I came to Hopkins. I just heard of this something called a Masters in Public Health program. Figured I'd give it a shot, see what happens. Loved it. And I think the one thing about epidemiology and infectious diseases is you can keep jumping diseases. And I'm someone who gets bored very easily. So if I don't like HIV, I jump to chikungunya for some time, come back to dengue. It's fun to just play around. And the crazy thing is like the same models that you use for prevention of HIV probably work for several other diseases like community leaders and peer opinion leaders and virtual intervention. So it's the way our programs in India and globally are structured, they're all just vertical. So you have like an HIV program, a TB program, and a hepatitis program, all trying to reach the same person, but not talking to each other, right? And so it's very easy to work across those programs. And that's pretty much what most of my focus has been over the past, I would say 15, 20 years, is really trying to figure out how do we take these efficacious interventions and deliver them to the people who actually need them. Because there are all these efficacious tools. We have antiretroviral therapy, we have DAAs for hepatitis C, we have vaccines for Hep B, but most of the people who need these medications and vaccines are not getting them. So really trying to figure out what those gaps are in the healthcare system and how you plug those gaps. So that's pretty much been most of my focus. And I'm happy to be a part of this. And I think another great thing about Hopkins is people like you, because we know that we can count on you to keep our work growing. So I think that's what is one of the most precious things about Hopkins is the next generation. Thanks, Ashish.
Thank you, Dr. Solomon. And how about Dr. Shet? You want to say a word now?
Sure. Thank you. Thank you all. It's great listening to all of this, and it's just it's funny how similar some of our trajectories have been. So I began my training in India in medical school, and then I went into pediatrics, and I did pediatric infectious diseases, and then I worked in the US for some time. But I got excited by the lab, actually translational medicine. So I had this circuitous pathway where I tried to learn some techniques in the lab. And these were the heady days of HIV cocktail therapy, as you heard. So there was all this activity about viral load testing and genotyping. And at that time also, we were realizing about children and how we didn't really know what to do with children, how to treat them, how to monitor them. That was the time that I went back to India and started working there. There was an estimated about maybe 500,000 children also born with HIV every year, and 30 to 50% of them would die by the time they were 2 years of age. So there was plenty to be done. So as I was practicing in India, it was interesting to see how the disease evolved and went from being a life sentence, fatal disease, to a more chronic disease. And it was really good to be a part of that. But at the same time, we saw plenty of other preventable infections like measles, diphtheria, pneumonia, and diarrhea. And this is not too long ago. This is in 2000, 2010, and so on and onwards. So I started looking at this broader picture of public health and how, as a clinician, it's hard to do as much compared to public health. And that's when I went back and did a PhD, and then I landed up at Hopkins, where I continue to work in the global space in vaccines, but predominantly in India, where vaccine equity is really critical, and as you just heard from everyone. But there was also this increasing recognition of the importance of primary healthcare to achieve these goals. And in the past 2 years, we established the Maternal and Child Health Center in India. And this is focusing on capacity strengthening and accelerating research in public health within the space of maternal health, newborn health, and child health. So within this, we launched a few courses. There was this national response to COVID and looking at the impact of women and children as a course that we've launched now with the Indian government. But also the pandemic really changed our focus. That we saw so much of the disruptions that's been happening in basic healthcare, nutrition. We learned about children being orphaned and how marginalized people really suffered with not just health, but so many other social determinants that are critical. But also some good things, in the coming back to HIV, actually, we are also doing a program on HIV empowerment, youth empowerment programs. And very recently I was chatting with Sunil, and some of the children who were born with HIV are now in their early 20s. They're actually submitting abstracts to the International AIDS Conference. It's wonderful to see that cycle. But we do multiple projects currently with partners in India, and we would love to talk more about this and get your engagement as medical students.
Thank you, Dr. Shet. And last but not least, we have Dr. Amita.
Thanks, Ashish. Thanks for including me. It's been great to listen to everyone's stories. So I am the odd one out, not trained as a medical doctor, but as an epidemiologist. And I found my way to epidemiology and public health on my way to medical school, on my way to thinking. I was working in a research job thinking that I would be on my way to medical school, but I took a course in epidemiology and it just fit. Sometimes things just make sense. And instead of medical school, I found myself applying to the M.P.H program at Hopkins, like Sunil. And, I thought I was coming to Baltimore for 11 months, and I was going back to Chicago where I'd come from. I think many people say that 11 months or 2 years or for the program, and then you find yourself years later. So I stayed for my Ph.D. And actually, when I was doing my master's, I was always interested in working on HIV in India. And I had a particular interest in epidemiology and prevention of HIV among female sex workers. And like Amita, I found myself at the door of Bob Bollinger, because at the time, I think it shows how much we've grown in terms of HIV research in India. But at the time, if that's what you wanted to do, you found your way to Bob's office. And Bob had all these rules about doing research in India. And at that time, it was particularly challenging for a student to ensure that you were going to get your project through and get your PhD. So he essentially told me, go get your PhD, do something else, and then come back to me in a few years when you're done. So I ended up focusing my PhD work on HIV and actually viral hepatitis domestically instead of female sex workers. I found myself working with people who inject drugs, in part just because of what was happening in Baltimore City. And I did exactly as Bob suggested. When I graduated, I went to him to see if there was any opportunity to work in India, because it was still on my mind. And that's when Amita and I actually met. And as she mentioned, we started our careers working on some projects together. And through some stops and starts and changes in projects, I actually found myself working with Sunil a few years later in South India and building in a different direction there. And I would say I was trained, as an epidemiologist, we were trained to bow at the altar of the cohort study. That was the gold standard. That's what I was trained to study. I was interested in the epidemiology, learning about the natural history, looking at how HIV and viral hepatitis interacted, clinical outcomes. But as we started work, Sunil and I together started a small cohort of people who inject drugs in Chennai. And as we started working with this population, we realized that there were so many challenges. We were studying, we were following, we were observing people for outcomes that we were interested in. But what we were learning about were the challenges that they were facing with respect to accessing care. So I became really interested in just what were individual and structural barriers to accessing, engaging in services that were basically available to the population, even free of charge in some places. And so I've spent the past, 5 to 7 years pivoting in that direction and actually working with interventions, implementing them in a variety of different contexts across India, testing them in different ways, but really all with the goal of improving the way we deliver services and this idea of taking services to people and tailoring them to people's needs rather than, starting with what we think the population needs, actually listening to them and trying to deliver services in a way that's acceptable and accessible to them. I think what I would say is that, our careers, we think about, we think that there's this linear path that we're on, or we have this idea of where we're going to end up. And sometimes we manufacture the story to look that way when we're standing here and looking back, but it's never like that. It's about taking opportunities and following questions that you're passionate about and working with populations and things change and evolve over time. And you just have to kind of go with the ride. So it's great to be here and I look forward to chatting more with you all.
Thank you for those wise words, Dr. Mehta. I think at this point we can kind of transition to more of a Q&A sort of format. And so if anyone has any questions, feel free to unmute yourself and jump in. Just to get the ball rolling, I'll throw a question out there. I would like to learn more about some of the ongoing projects that you all are working on and that you feel very passionate about. I'd love to hear about that. And anyone feel free to take the seat.
I'll take a quick stab since we haven't mentioned the word tuberculosis. And tuberculosis is something I study a lot of. And India has 27% of the world's burden of TB. So 1 in 4 people walking on the planet who have tuberculosis live in India. And before COVID, it was actually the #1 infectious disease killer. It surpassed HIV a few years ago after we figured out how to treat it. So it's a huge problem, and it's got it has social determinants, it has biology, it has a lot of actually exciting science happening. It's an age-old disease, which for 40 years had no discovery. We were using the same drug combinations and really had not had any new insights. And along came HIV, and I think some of the funding and thinking about how to reinnovate new drugs, and now hopefully new vaccines. So BCG has been around for over 100 years. So what we do in India, our team is largely based in Pune, but we now have a network of 9 Indian sites that the Indian government funds, and the NIH funds the US 5 universities. We formed a consortium called Report, and we have cohorts. So like Shruti was mentioning, the cohort is your gold mine for epidemiological research. And we longitudinally follow adults who develop TB, children who develop TB, as well as pregnant women who develop TB with pulmonary TB, extrapulmonary TB, and we follow them for their outcomes, and we follow their household contacts. And we basically do work to figure out what are the factors driving treatment outcomes? What are the factors driving progression from exposure to either active disease or resistance to infection? And so that's led to a whole host of opportunities for students, for staff, for collaborators. So if you're interested in lab science, new diagnostics or biomarkers, epidemiology, social science, we've sort of layered all of that into that consortium. So that's one area. The other area is we're testing new drugs and vaccines for TB. So we're looking at new compounds that are reaching phase 2, phase 3, and doing clinical trials. Now, for medical students, getting involved with the clinical trial is not for the faint-hearted. It'll take years. So what I would say in that scenario is there may be opportunities to do sort of, you know, an epidemiologic study or a social science type of study, or every now and then you get lucky. And Priya Singh, who's a medical student, a fourth year, who might know, she came and approached Dick Chason and I, and so she's actually getting to do 2 papers from 2 clinical trials where we had excess data and nobody had time to write up. So there's an example where a medical student can sort of get involved where we, you know, so definitely different stages. And so she's looking at isoniazid therapy in pregnant women and outcomes of their babies. And the other study is looking at incident pregnancies on women who are in clinical trials getting preventive therapy. So that gives you some examples of some of this work and opportunities for students. Others?
I can go, I guess. I'll talk less research, but I'll talk about the other program, which is the USAID program, which is PEPFAR funded. And Shruti and I do this similar research, so she can cover the research side of things. So I think some of the most exciting things I've done is probably currently through this USAID funding, because we're actually working with the government of India and the state AIDS control societies and all the communities. So we actually established one of the first comprehensive clinic for transgender communities in India and Hyderabad. And so that was something that we didn't think was going to be possible like 15, 20 years ago, but it has become a reality. So we right now have 4 clinics across India. We have one in Hyderabad, one in Pune, one in Thane, and another one in Lucknow. And so these are providing HIV services, tuberculosis screening, viral hepatitis screening. But in addition to all that, it also provides services like laser therapy, hormone replacement therapy, gender referrals for gender reconstruction. So it really is addressing that individual as a whole. So the structure of the USAID grant is like it's like a program. So it's all implementation science. So there's a lot of service utilization data. There's a lot of data that's being collected at these centers in terms of who's coming in, what services they're doing, what are their outcomes, which is all available. And we have limited time, and it's not really like a research program. So no one really works on this data. So there are medical students who are interested in these particular aspects. We can definitely talk to you a lot more in detail and tell you what it is. And like Amita said, I think some things are very easy to get done, especially if the data already exists. But if you're trying to start collect new data in India, especially among children in certain populations, it can take an extremely long time. Like I know I've been struggling with the IRB for one study we're trying to get done with another medical student from Hopkins. The other area that we're working on in India, which is kind of interesting and fascinating, and we would really think you probably have more insight into this area than all of us because you are the right age in the generation, is like this whole virtual space and like these online populations. Because as many of you know, during COVID and even pre-COVID, there's been this preponderance of like cell phone technology, and everyone's on cell phones in India, everyone's on WhatsApp, and apps like Grindr, Tinder, Planet Romeo, they're all over the place in India. So there's a lot of transactional sex and meeting partners happening in these virtual spaces. So we're actually running these programs to try and reach these populations. So we have these people called virtual sexual health workers who go onto these different platforms, chat up clients, tell them I'm a health worker, are you interested in getting tested? And what we're finding is we're tapping into a population where the HIV prevalence is about, well, the HIV test positivity is about 5%, which is almost 25 times higher than what it is in the general population in India. And most of these people have never been reached by services before, never been tested before. So there's this huge area that's completely understudied, but it seems like that's where there's going to be a lot more interventions. We've started with HIV, but just given what COVID has done and that whole penetration of like telehealth and telemedicine, I feel like that is the future. And like Shruti already mentioned, is like, how do you leverage technology to meet people where they're at? And I think that's pretty much where healthcare is going. I don't know how many of you have been to India lately, but most people in India order Swiggy. right? Like no one goes out for food. They sit at home, pick up their app and click on something, it comes home. And I just feel like that's where healthcare is going to go with the way things are changing. There already are these apps in India, but they haven't picked up yet. So just figuring out how do you deliver quality, accessible, affordable healthcare through these virtual platforms, that definitely is the future. We've started scratching the surface, but would definitely be interested to figure out what your thoughts are, because I have no idea how to use TikTok, but apparently that's what we should be using if you want to tap into these populations. So I'll stop there. And I don't know, Shruti, if you want to talk about the research.
Sure, I can pick up a little bit. I mentioned this idea of service delivery being a focus of our research over the past, I guess, 10 years now. And so we've done a series of community randomized trials evaluating the impact of various service delivery models. And the first, which I'll mention because it sort of feeds into where we are today, was this idea of just a simple idea of integrating services. The idea that if a person has to go one place to get an HIV test, another place to get treatment if they're positive, another place to get managed for their sexually transmitted infection if they have one, another one to get needles if they're a person who uses drugs, another one to get medication for opioid use disorder, you're going to lose people, or they're going to access one service and not the other. And so we've been working over the past 10 years to essentially, with the Indian government through public-private partnership, integrate these services under one roof and essentially evaluate whether that improves outcomes with respect to HIV, as well as substance use and sexual risk behavior. And so we've done that through these large, challenging community randomized trials. And so we've actually been working across 22 sites in India. And we randomized, the first round, we randomized 11 to receive this integrated care intervention. 11 just had all services available, standard of care. But as part of that, we actually run community surveys prior to and after the intervention. So we sample 1,000 people in each of these cities, in each of these risk groups at these different time points. So it provides, I mentioned that because we've had students both analyze these data because the surveys are large and typically, even though we have one outcome or of interest for the trial, we collect information on many other issues, stigma, social determinants of health, TB, hepatitis C, HIV, you name it, it's in the survey. And so we've had students that have used the data to just analyze and write papers. We've also had a couple of students that have gone to the clinics back when we used to travel and gone and spent some time there to actually work and get involved with field work, which I think has been incredibly rewarding for them. The second phase, and essentially that was the first trial that we conducted. Right now, after we actually saw the first phase, it worked essentially, but not very well. It improved uptake of HIV testing, but we saw no impact on treatment uptake. And so in the second phase of that trial, we essentially scaled up an integrated care center in every city, but then we randomized half of the sites to receive non-financial incentives for HIV care. And unfortunately, that didn't seem to work either in the sense that, and I think one of the challenges is that it works, but it's hard to show that difference without a large number of sites, but also there's a lot of other things going on in the community. And so when you try to see community level change, you've got to see big change to actually demonstrate that impact with statistical significance. So we have no doubt that we're actually improving outcomes. We're just not able to show that statistically, but it does allow us to then ask another question. So we're on the third round of that set of trials, and we have one trial that's focused on integrating hepatitis C treatment for people who inject drugs into the HIV setting through a novel design that we're using. It's called a precision randomized trial, again, trying to tailor the intervention to people's needs. And then we're about to launch another trial comparing a couple of different interventions for antiretroviral therapy. So two things. One is comparing community-based antiretroviral therapy to government center antiretroviral therapy, and the other is initiating people with people who use drugs in particular. If they come into the clinic that day, you got to get them engaged at that moment. If you say, let me test you and then come back in 3 weeks and we'll start your therapy, then they're already gone. So the idea is initiating them right away to see if that improves outcomes. And so again, just lots of data and lots of ongoing field-based data collection for people to engage in.
Yeah, I can speak a little bit about some of our work. I mentioned childhood pneumonia. pneumonia is still one of the biggest killers of children under 5, about after the neonatal age group. So it's still a huge problem worldwide. And India contributes about 20% of all childhood pneumonia deaths globally. So it's really huge. We have an effective vaccine, the pneumococcal conjugate vaccine, that should cover about maybe 40 to 50% of pneumonia deaths, because pneumonia, it's multiple pathogens, but strep pneumonia is one of the most common ones. India rolled out the PCV in 2017, but it hasn't reached the entire country yet. So only about 30 to 40% of the children in India now get the vaccine routinely. So we're looking at 4 states in India to look at childhood pneumonia outcomes, children who've received the vaccine and who haven't. And we'll look at multiple aspects. So one is the serotypes. There are about 96 different strep pneumonia serotypes, and the vaccine contains 13 at the most. That's what we have. We have a PCV10 and a PCV13. So we're looking at vaccine types, serotypes that are prevalent in these children, carriage, as well as invasive pneumococcal disease. So it's a project that's really taught us a lot. When we started this project about, say, 3 years ago, it was so hard to get pulse oximeters across all these different hospital sites. And now it's like everybody has a pulse ox in their pockets, right, after COVID. So things like that have changed. We've also noticed after COVID that the mortality among children who present with pneumonia it's just gone through the roof. We're trying to understand why it wasn't built into the study. So that there are many different things that can be added on. We did have a medical student 2 years ago who went to India and spent time looking at these sites. So it's a great place to have all these different aspects studied. We also do a few other smaller projects through the Maternal and Child Health Center, focusing on immunization coverage and equity. One interesting aspect is the missed opportunities for vaccination. We found that in health facilities, children come for acute conditions. And if you look at them carefully and look at their vaccine status, many of them are not vaccinated. And these are children who've been through health facilities. So we went into the reasons to find out why and how we can overcome these missed opportunities. So that's another very interesting aspect that came up while we were doing these other health facility studies. COVID vaccine rollout is another big issue, big program in India. Vaccine hesitancy is there, but the traditional reasons of hesitancy that we often encounter here, that's not the issue in India. So we're trying to understand what the issues are. One of the things is that many people don't have their paperwork, like the equivalent of the Social Security card is the Aadhaar card in India. And without that, it's hard to register to get the COVID vaccine. So that's something we are trying to, this is more implementation of trying to help these marginalized populations get vaccinated. So quite a few projects, but I'd be happy to talk more about this, or on a one-on-one basis if you like, or by email.
I'm happy to follow up, or if you want to move to other questions, that's fine too. But, much of my work, well, I'll keep going unless I see a question in the chat or a hand or something, but most of my work up till now, up till recently, has really been around equitable access to care in both public and private sectors in India. But for the last few years, we've been working in Uttar Pradesh really around policy and institutions. We've been asked by the government to help restructure the ministry. And we've gone through several ministers and chief secretaries since then. And they still want us to hang around and help them reorganize a bureaucracy that is always challenging. It's one of the parts of things that are isn't designed to move. So partly it's, how does a directorate or a Ministry of Health actually perform its functions? And looking at those things, they're very good at appointments and moving people around, and they spend a lot of time in courts and around disputes. And we had a focus really on trying to fulfill public health functions, particularly around disease surveillance and response. Lo and behold, that's become very important since we started, as well as around health promotion and policy formulation, particularly around human resources for health, and a big issue around use of data. How do you use data to make good decisions? So we've actually been working on developing public health competencies to help them create a public health cadre. We've been doing training of, because mostly what happens, you have medical students and people who graduate from medical schools, then put into positions at the block level and district level where they actually have public health functions that they're not trained to do. They're trained to see patients and to work on clinical teams and start thinking about populations and public health and management issues is different. So we've been doing training, we've been building up basically defining public health competencies and then looking at data to help inform decision-making and creating this, or helping with the systems in order to use it. And much beyond the technical parts, we've had students actually looking at, well, how is data misreported? How is it misused because of the incentives that are put in? So people use data in different ways. And so how do you actually create data that is trustworthy and then create policies that are driven by the data are things that we're working on. We've had lots of students join us. We've plenty of master's students come out, as well as a couple of doctoral students did their dissertations on it. So that's it. But again, this isn't really been work around clinical, but it's about helping clinicians in many cases to do public health work in India. So I'll stop there and turn it back over to you, Ashish.
I don't have a question, but I just wanted to truly thank everybody for sharing what they've done. This is N=1, but as a simple medical student, it's actually truly inspiring to hear the kind of stuff that hopefully one day we will be able to achieve. And so I just wanted to appreciate everything you guys have said has been amazing, and it's been so cool to hear.
Thanks. I mean, take advantage of the opportunities at Hopkins. I mean, this is a place where you can network, you can ask tough questions and try and join projects. I mean, this is a place where like none other where you can do that. And hopefully the India Institute is there to be able to help you to do that easier, to find people to connect to, and it's a great privilege to be at Hopkins and take advantage of it.
I have to say that the student, as a medical student, don't underestimate yourself. You contribute a lot to these projects, and it sounds like we're doing all these grand projects, but we take a lot of help, sustenance, and inspiration from students. For instance, the Missed Opportunities project that we eventually got funded through Grand Challenges, it came from an idea and observation by the student who was just walking around with us. We were looking at the charts of patients, of the children who were admitted for pneumonia. And she said, why are they not vaccinated? And then we went to the next bed and no vaccine, next bed and again. So we thought, these children are all in hospitals, and why should they not get vaccinated? Because the vaccine clinic is just next door or in the next building or another floor, right? So that's how ideas grow. So I want to thank you and appreciate medical students.
I think the only thing I would add to that is if you send us an email and don't respond, maybe at least for me, if I don't respond to your email for a week, send another email. You're not bothering us. There are many of us who look at that email on our phone, think about responding and forget. And I'm guessing from Amita and Shruti laughing, it's a common theme among most of us. So you're not bothering us. Just keep sending those emails if you don't hear back from us.
It's gotten worse since COVID, I would say. So definitely, we're never upset about that.
And I put in the chat a couple of things that are part of the global health. One is a Fogarty Fellowship. So I've had medical students, doctoral students, and then of course, if you go into residence, there's a different award, the Paul Lietman Award. But There are funding opportunities for your summer experiences, for example. And then you also have the scholarly concentration where we've had students go to India for that. And then the other thing is the field placement awards. The Fogarty Scholarship requires you to spend 11 months. So unless you've got sort of a 5th year or some, break in your training, you usually can't avail yourself. But I will say it's been amazing for those who have been able to go and live for 11 months and get fully funded and work within a project. Hopefully within the India Institute in the near future, we'll be looking to set up some more formal student exchange, student sort of, we'll have on the website, one of the things we're going to be doing, we just launched it last week, but we'll put in student opportunities. So we'll be collecting information from faculty such as those on this call and others who can sort of post if they have special positions or are looking for help on their projects. How about any other questions from Ashwin or Robert or Mark or Rinda, Pranjal, Shrey? Well, Shrey, you gave us such nice comments. Divya, Shrey, and Ashish are all, and Pranjal are all involved with the COVID response. They worked with a few different groups, including Sunil and Shruti, but you also developed materials and for things that we did, which we're very thankful for.
They're busily analyzing some data now for abstract submission deadline on Friday. Doing a great job.
That's awesome.
That was an example of a project that normally wouldn't happen that quickly, but because of COVID, it happened. Normally projects don't happen that fast. I think we just got lucky there.
If one gets lucky in COVID, but
Thanks, everyone. I don't see any other questions from my end, but echoing what Shrey said, we really appreciate you guys taking the time. Your insights are really helpful, and it really motivates us to follow those questions, like Dr. Mehta said. And I guess it would be, I guess I could talk a little bit about some of the stuff that Divi, Shrey, Pranjal, and I have been working on. But basically, like when the pandemic was in full swing in India, the Delta wave, it was looking very, very scary, and we wanted to do something about it. And so we kind of just pulled our heads together and just thought about all the different resources that were available to us, both within Hopkins and outside of Hopkins. And we reached out to Dr. Gupta, and she's the one who put us in touch with Dr. Solomon and Dr. Mehta, and we were able to, kind of scramble and put together kind of a rapid antigen testing program with the help of YRG Care. Now that's the data we're analyzing. But in addition to that, we were able to network with people, with medical students and trainees at different levels throughout their training at different institutions, and really do some meaningful work. So I think it just echoing what everyone really had said in this session so far, I think it's really important to really ask those questions and pursue those answers that you feel really passionate about. So thanks everyone for really taking the time tonight.
Great.
And if you feel comfortable and you don't mind, feel free to throw your emails in the chat. If not, I can just email it out to the attendants later on.
Oh, and I should say that Tanya Chatterjee is our program manager. So you may want to, in terms of also finding out more about the India Institute, or if for some reason you can't get in touch with us, you can bug her. Ashish, you have her email. All right, excellent. Well, I'm glad SAMSA has been formed, and we look forward to seeing ways, and if Ashish, if there are ways the medical school or other opportunities you think that from a student perspective would be good to convene, one of the things with the global health course that Bob Bollinger used to do, then Natasha did, and now I think Larry Chang and is taken over. It's like the 3-day intersession. I do the small group discussion with others, but that's a good opportunity also. Sort of, we used to have medical students from India and from Ethiopia and from Uganda, and also on the screen to be part of the case-based studies. So if that's something that's of interest, we do have once a month, Matt Robinson now leads this grand rounds with 5-6 hospitals in India, and they discuss cases. And it's mostly infectious diseases, but those are where all the medical students are sitting around with their attending, and they're all pontificating about cases. So if that's something of interest, we can send you that link as well. But lots of things to consider, and we look forward to having more engagement. All right,
Thanks,
take
everyone.
care. Good night.
Thanks,
Bye.
everybody.